say good afternoon to all of you. We are so happy to have you and thank you in advance for attending our session today, which will be an engaging discussion on the maternal mental health crisis in our country. We have two experts lined up to speak to you today, and they will share topics and recommendations that will help you as you look to increase your knowledge on and around maternal mental health, recent federal legislation and its impact, and models of implementation. Next slide, please. My name is Shannon Lee, and I'm a Senior Program Manager at PCDC. And again, I'm excited to be here with you all today and very much looking forward to our discussion. Next slide. So for those of you who are not familiar with PCDC, we were founded in 1993 as a nonprofit, and we are dedicated to expanding and transforming primary care in underserved communities to improve health outcomes, lower health costs, and reduce disparities. Next slide. So to be clear, I will read the disclaimer on this slide word for word. The views, opinions, and content expressed in this presentation do not necessarily reflect the views, opinions, or policies of the Center for Mental Health Services, CMHS, the Substance Abuse and Mental Health Services Administration, SAMHSA, or the U.S. Department of Health and Human Services, HHS. Next slide. So this year, we're continuing with the theme of operationalizing integration, and I'd like to highlight the work that we did in this space over the course of the last year. So this slide actually shows examples of our tip sheets that were created in support of last year's content. These tip sheets speak to mitigating burnout through integrated healthcare, collaborative care management 101, maternal mental health, kind of from the perspective of that 30,000-foot view, and also ways in which you can provide equitable and responsive care to your patients and also your clients. Next slide. I'd also like to highlight our Integration at Work SAMHSA webinar series tip sheets. These provided a roadmap for behavioral and primary care collaboration. And I think it's really critical that we highlight how we're leaning into integrated care and working across organizations to improve outcomes. Outside of this particular series, one of our senior directors, Henrietta Croswell, supports work associated with the National Council for Mental Wellbeing's Comprehensive Healthcare Integration Framework. And that is a new framework that we hope to discuss in future webinars. And it kind of guides the implementation of integration of physical health and behavioral health. And that can help providers, payers, and population managers measure progress in organizing the delivery of integrated services. So whenever you receive this slide deck next week or in the next couple of weeks, I encourage you to check out all of these resources, all of the tip sheets, and then also come back for our future webinars. Next slide, please. So before introducing our speakers, I want to get a little bit more information from you through our poll. So just let us know where you work, your primary role, and then also how you would rate your current skills and comfort in discussing maternal mental health, associated federal legislation, and also models for implementation. And then if you don't see your setting or your role listed, please feel free to drop that in the chat. We just love to know where you're joining us from. And so we'll give you a minute to complete the poll. Okay, a few more seconds on the poll and just waiting on that to close out. And then also as a reminder, at the end of today's session, we will transition into our half-hour open office hours session. And then again, just as a reminder, today's slides and the recording will be made available next week. So we'll make sure that we send you that information via email. So it looks like most of you that are here today are from an integrated care setting. About half of you are from that setting. We also have some people from behavioral health and primary care. And it also looks like the majority of those that are here are either nurse practitioners or registered nurses. And we see some people dropping some information in the chat. So thank you very much for sharing that. Okay. Next slide, please. So now I am going to introduce our presenters. First, we have Adrienne Griffen. She is the Executive Director of Maternal Mental Health Leadership Alliance, and that is a nonpartisan, nonprofit organization dedicated to promoting the mental health of mothers and childbearing people in the United States with a focus on national policy and health equity. MMHLA advocates for improved maternal mental health care and serves as a clearinghouse of information related to maternal mental health. MMHLA's advocacy efforts have led to almost $200 million in federal funding for maternal mental health programs at both the national and the state levels. Adrienne serves on the board of directors of the Marseille Society of North America and the Mental Health Liaison Group. She also founded Postpartum Support Virginia, which she led for 10 years, building a statewide network of support groups and maternal mental health coalitions that have helped thousands of new mothers. Adrienne graduated from the U.S. Naval Academy and has a master's in public policy from Harvard's Kennedy School of Government. She lives in Arlington, Virginia, with her husband and 3 young adult children. And I'd also like to introduce Joan King, who has provided consulting, training, and technical assistance to individuals, organizations, regions, and states in developing recovery-oriented systems of care and integrated systems of care for more than 30 years. Prior to developing a consulting practice, she worked across a variety of healthcare settings. Joan brings a perspective of a family member and clinician combined with a belief in the power of relationships and communities to create context for healing in her work. Her focus areas include primary care behavioral health integration, wellness-oriented trauma-informed services, community partnership development, and rural and frontier challenges and solutions. So Adrienne and Joan, we can't wait to see what you have in store for us. And now, Adrienne, I pass the baton to you.
Great. Thank you so much, Shannon. Really appreciate that warm introduction. And thank you all for being with us today, taking time from your busy lives to learn about maternal mental health. So I often joke that I call myself an accidental advocate. Early in my career, if you had told me that I would do women's mental health, I probably would have laughed at you because I was in the military. I graduated from the Naval Academy. I worked at the Pentagon and the White House. I worked for the United Nations. I was really focused on international relations, and I really thought I was going to rule the world. And then I had this beautiful baby boy, and he kicked my ass and really sent me into a deep understanding of mental health issues in a way I'd never experienced them before. After he was born, I was really overwhelmed, anxious, just couldn't really get my head above water. I had a toddler and a newborn, and I was really, really drowning. And the hardest part is that it took me about 6 months to get the help that I needed. And during that dark time, I decided I needed to do something about it. So here we are, flash forward 20 years later. My son is great. He's getting set to graduate from college. We all have survived. We have a lovely family, but it really took a real toll on us. And so after my kids, went back to school, started, got the youngest one off to kindergarten, I dipped my toe in the water and started volunteering for an organization called Postpartum Support International, which is a fabulous organization. They provide a lot of support to new moms and families. And then eventually I expanded and started my own nonprofit in Virginia. And then about 5 years ago, it came to MMHLA to really focus on national policy. And so I am driven by my personal experience as well as my education, which was, as Shannon said, I have a master's in public policy. So funny how all the streams come together in your life. Okay, so what are we talking about? Next slide, please. So, right, a word or two about MMHLA. As Shannon said, we advocate for national policies that focus on compassionate mental health care during pregnancy and the year following pregnancy. So staying very narrow and very clean on what we focus on. Next slide, please. So the happiest time in a family's life, right? Bringing a new baby home. Look at all of these beautiful pictures. Everybody looks so happy and clean, and all the babies are sleeping. Isn't this just lovely? Well, let's go to the next slide. Not always. This was a little bit more what it was like at my house. I love this guy in the upper left-hand corner who's screaming. And then, literally at my house, it seemed like somebody was always awake and crying. And that little one on the bottom center in the little blue and white check dress, that is one of my daughters, yes, having her fit. It was a bit of a shit show at my house, to be honest with you. So next slide, please. So what are we talking about? Here are the facts. I'm going to dig into each one of these throughout my presentation. So first, we know that the United States is in a maternal mortality crisis. Anybody who works in the field of maternal mental health, maternal health knows this. The facts and figures that we have been hearing for the last 5 to 7 years are just dismal. We also know, fact number 2, that mental health conditions are the leading cause of maternal deaths. But we also know that we can do something about this. These illnesses are highly preventable, highly treatable, and we're taking steps at the national level to address these. So next slide, please. Let's dig in. Fact number 1, the United States is in a maternal mortality crisis. Next slide, please. What do I mean? Maternal mortality are the number of deaths per 100,000 live births. In the United States, not only has maternal mortality been on the rise, but we actually have the worst maternal mortality rates of all developed countries. The chart on the left shows, where I've circled in red, the US's maternal mortality rate. And then just to the right, you actually see what the maternal mortality rate is for Black women. It is embarrassing, it is abysmal, and we ought to be ashamed of ourselves. Next slide, please. Looking again at US maternal mortality rates. Again, I've circled the rate for non-Hispanic Black women. We see that the maternal mortality rate for all groups of women have increased. And in fact, it actually doubled during the pandemic. But as with many issues, we see that women of color and women who live in low-income neighborhoods are disproportionately impacted by these illnesses. Next slide, please. So let's just unpeel this a little bit. So we know that there are a couple of things, or many things that contribute to maternal mortality. I'm just highlighting 2 here. So the COVID pandemic, of course, we saw an increase in deaths. 25% of maternal deaths in 2020 and 2021 were due to the COVID-19 pandemic. And again, we know that women of color and women who live in low-income neighborhoods are disproportionately impacted, primarily because of the social determinants of health, where they live and where they work. They worked in frontline jobs where they could not work from home. They live in more crowded homes where perhaps the illnesses were spread more quickly. They face challenges accessing the internet, having privacy, accessing healthcare. All of those reasons really contribute to the disparities. And then we know that mental health is really a leading cause of maternal mortality. There was a study done by the Centers for Disease Control and Prevention that showed that 22% of maternal deaths in 2017 and 2019 were actually due to suicide and overdose. That is the leading cause of death for all groups except non-Hispanic Black women. And so this was the first time that we had this conclusive data that pointed to mental health issues as the leading cause of maternal deaths. Next slide, please. And I'll tell you, every time I say that, it's almost like I'm punched in the stomach. Like, how is this possible that mental health conditions are the leading cause of maternal deaths? Next slide, please. I'm going to dig into this a little bit. So again, the facts: mental health conditions are the most common complication of pregnancy and childbirth, and suicide and overdose combined are the leading cause of maternal mortality. That's why we do this work. Next slide, please. So a few facts and figures about maternal mental health. We know that 1 in 5 pregnant or postpartum people are actually impacted by maternal mental health conditions, and 1 in 3 in high-risk groups, like I said, women of color, women who live in low-income neighborhoods, immigrant mothers, military mothers. There's lots of at-risk communities. We know that 75% of those impacted actually remain untreated, and that 100% of maternal deaths due to maternal mental health conditions are preventable. And the cost is significant, $14 billion each year in not treating these conditions. Next slide, please. As I said, there are certain groups that are at high risk, including people with a history of mental health conditions. In fact, we know that previous experience with a maternal mental health condition is the #1 predictor of experiencing another maternal mental health condition. We know that people who have experienced trauma are at higher risk, as well as those who lack social support, especially from their partner. As I mentioned, individuals of color, those who live in low-income neighborhoods. Parents with a baby in a neonatal intensive care unit are at increased risk, we know, for anxiety, for PTSD. And as mentioned, military mothers and spouses. In fact, we're getting set to release a fact sheet on the impact of mental health conditions on women who are in the military or who are veterans. And as I said earlier, immigrant parents, oftentimes they're away from their family of origin, again, maybe working in low-income jobs where they're not able to access healthcare. And so on with the risk, the number of individuals who are at higher risk. Next slide, please. So why should we care? Well, let's talk about the impact on the mother. First, we know that women who are pregnant and have untreated maternal mental health conditions are more likely to not have adequate prenatal care, have poor nutrition, and use substances, and they're more likely to experience physical, emotional, and sexual abuse. And then we know that women who have untreated maternal mental health conditions in the postpartum period are more likely to be less responsive to their baby's cues and then have fewer positive interactions with their baby. And then that sort of becomes this negative downward cycle. We know they're also more likely to experience breastfeeding challenges and question their competence as mothers. Next slide. And the impact on the baby is significant. We know that children born to mothers with untreated maternal mental health conditions are at higher risk for all kinds of negative birth outcomes, things like low birth weight, small head size, preterm birth, even stillbirth, and longer stays in the NICU. And we know that children living with mothers with untreated mental health conditions are at higher risk for things like excessive crying. Remember, I said there's that impaired mother response, which can lead to impaired parent-child interactions. These children are also at higher risk for experiencing behavioral, cognitive, or emotional delays. And mental health conditions in the home are well known to be an adverse childhood experience that can have long-term negative health impact on the child. Next slide, please. As I mentioned earlier, the costs of untreated maternal mental health conditions are significant. There's the untold costs, things like the impact on the relationship with the partner or other children in the family. Some parents decide not to have any other children, and there's really no way you can put a price tag on that. We also know that there are societal costs. There was a study that was done in 2019 that shows the costs are about $32,000 per parent-child dyad. And that's addressing those poor birth and health outcomes that I talked about, as well as accounting for lost wages and productivity of the mother. So that's a total of $14.2 billion each year for our country. Next slide, please. So maternal mental health has bubbled up as a national priority. Recently, the Institute for Medicaid Innovation did a survey and a series of focus groups asking different groups to identify the most important topics in women, gender, and maternal health. And the number one issue across all of these domains, federal policymakers, state policymakers, medical health plans, and maternal health leaders, the number one issue they identified was maternal mental health. So in fact, the Institute for Medicaid Innovation recently held a two-day workshop to develop a 5-year strategy around addressing mental health through Medicaid. Next slide, please. Okay, so now the good news. Together, we can save lives. So I'm just going to talk to you a little bit about things that we've been doing, different pieces of legislation, and national priorities that are moving forward. So next slide, please. So the first is federal legislation that we, Maternal Mental Health Leadership Alliance, have taken the lead on. 2 pieces of legislation, the first passed in 2015 and the second passed in 2022. And the goal of this legislation is to provide funding to states to implement a program that was found successful in Massachusetts. And so what we did was elevate this program and get funding in 2015 to provide grants to 7 states to replicate this program. And I'll talk a little bit more about what that program is in a second. When this funding announcement was announced, 30 states and territories applied. So people were eager and ready for this funding. And that funding was from FY 2018 to 2022. So in the federal government, they like to fund projects for 5 years at a time. So once that funding was up, we came back and introduced this new legislation that basically reauthorized and expanded these programs. And so now 12 states have received funding, and this is now for 2023 to 2028. Next slide, please. Another piece of legislation that we have passed is to create a maternal mental health hotline. So I remember when I came to this job 4 or 5 years ago, and I went around and I was looking at all the different government websites. So the Centers for Disease Control and Prevention and Health and Human Services and the National Institute of Mental Health. And they all listed, here's the signs and symptoms of maternal mental health conditions. And if you need help, call Postpartum Support International. As you might remember, that was the organization that I started volunteering with way, way back, I'll say almost 15 years ago. And so I knew that PSI is a very well-meaning organization, but it's a small nonprofit. And so I thought to myself, wait a second, if the federal government is really holding up this small nonprofit as the go-to organization, perhaps they ought to fund it in some way. And so we came up with this idea of having a national maternal mental health hotline. PSI had a warm line where you could call and leave a message and somebody would call you back. And I was like, wait a second. If I'm up in the middle of the night, as I remember being, feeding my baby, feeling all alone in the world, wouldn't it be great if I could talk to somebody? And so we developed this idea of establishing a national maternal mental health hotline. Postpartum Support International ultimately won the contract, so they do staff that hotline. It is a 24/7 voice and text hotline providing services in English and Spanish. The counselors on the hotline are all mental health providers or maternal child health care providers or certified peer specialists. Most of them are women with lived experience. I know many of them who work on the hotline, and it's because they couldn't find help when they needed it and they want to give back. So it was launched on Mother's Day in 2022, and the hotline helps about 1,000 people a month. And there's the phone number, 1-833-TLC-MAMA. And I have stacks of little cards about the hotline. You can go online and get these little cards, pass them out to your clients or your patients, and really encourage them to take advantage of this great resource. All right, next slide, please. Last year, the White House actually addressed maternal health by issuing a blueprint for addressing the maternal health crisis. And it looks across all different aspects of access, systems of care, data, workforce, and support systems. And the stated goal for the blueprint is that the United States will be the best country in the world to have a baby. Well, if you recall back to those statistics about maternal mortality, you see we have a long way to go. There were specific call outs in the blueprint for addressing maternal mental health, including things like extending Medicaid for a full year postpartum, launching a postpartum depression public awareness campaign, increasing funding for the hotline and those state grant programs, and some other things. So we see that it is a whole government approach to addressing maternal health and maternal mental health. Next slide, please. And the states are also doing things. Many states have launched coalitions or task forces. They've issued proclamations or resolutions, awareness campaigns. Some states have requirements that pregnant and postpartum people be screened or that providers be educated. They have launched intensive treatment programs for those who need more intensive care. As I mentioned earlier, Medicaid has been extended in many states from 60 days postpartum to a full year postpartum. And most states, almost every state now has a maternal mortality review committee to look at the causes of all maternal deaths. And then perinatal quality collaboratives, which help hospitals implement programs to address maternal health. Next slide, please. So I mentioned that MMHLA was successful in advocating for funding for state programs called psychiatry access programs. And these are population-based programs, usually at the state level, that provide 3 specific things. Number 1, education for frontline providers. So we often hear from obstetricians and pediatricians and family physicians that they don't receive training on these topics. And so part of these programs goes out and trains primarily obstetric providers who then can also have real-time psychiatric consultation. So if I'm an OB and there's a patient who's in and she has symptoms that I don't know how to treat, I can call and talk to a psychiatrist in real time. And then these programs also offer resources and referrals. And so you see the purple states are all the states that have launched these programs. I think now there's a total of about 28, which is great. When we started this, there was only 1 in Massachusetts. And so we're really, really happy to be able to be providing this kind of funding so that states can create these programs. Next slide. And then finally, I think this might be coming up on my last slide. We at MMHLA have launched a project called the Perinatal Mental Health Education and Screening Project. This is a multi-year collaborative effort to ensure that all pregnant and postpartum people are not only educated about, but screened for mental health conditions and provided access to resources for recovery. And so the first year we spent synthesizing existing screening guidelines into a cohesive approach focused primarily on when to provide this patient education and screening. And what we've been chipping away at now are addressing the barriers to screening, which we hear over and over again: lack of education for frontline providers, lack of reimbursement, as well as lack of resources for those impacted by these illnesses, and then screening tools that need to be updated. They're not fully comprehensive. Many of them are a little bit out of date, not culturally and racially sensitive. And so we're working on addressing all 4 of these barriers to screening and care. Next slide. So the good news: maternal mental health conditions, I said early, are temporary and treatable. Pregnant and postpartum people are engaged in the healthcare system. They are visiting their doctors all the time. We have ample opportunity to engage with them on these important issues. Parents, babies, and families can recover. We know that there are evidence-based prevention and treatment options, as well as increasing number of resources for both providers and patients. Next slide. And so I just want to end with this quote: "Mothers are the heart and soul of every life they touch. In them lies the beauty, depth, and grandeur of life." And that is why we continue to work in this field. So thank you so much. I'm looking forward to hearing from Joan to hear what she has to say.
Thank you, Adrienne, and thank you so much for the work you do. This is the first time Adrienne and I have had a chance to present together, and I was just listening to you, just being very grateful that you are in the world and working alongside those of us who may be working a little more on the ground. So I'm Joan, and Shannon did a little bit of introduction. What's not in my introduction that I want to just kind of add here is I also am the mother of 3 grown daughters, one of whom I just want to say finished the Richmond Marathon on Saturday in under 4 hours. I'm so proud of her. And have 7 grandchildren now. And so to be able to come back around at this stage in my career and be engaged here with maternal mental health and substance use issues is really an honor and a privilege for which I'm very grateful. I want to talk to you specifically. I love that Adrienne left on this good news, because I think we are seeing some good news in Montana. So if you can go to the next slide, I'd like to talk to you about one of the states that got that original federal grant, and we just got another 5 years. And Montana has, yes, that's what we said too, Adrienne. Even before that grant, the Montana Healthcare Foundation, which is a healthcare conversion foundation in Montana that was formed when Blue Cross went from not-for-profit to for-profit in Montana and spun off a foundation. The foundation, one of their areas of emphasis really has been for years, even before we moved into actually developing practices focusing on perinatal mental health and substance use, was this area of maternal health. And there were lots of reasons for that, specifically in Montana. So let's go to the next slide and let me talk about the story a little bit. I've had the privilege of working in Montana as a consultant over the last 8 years. And before we started this approach to a different approach to care, which I'm going to talk about, Montana had the highest per capita rate of children in foster care of any place in the country. And as you can see here, 64% of those were removed because of parental substance use. And that's a very unhappy statistic. Underlying that also is the unhappy statistic that many of those children were in Native families and were not always placed with other Native families. So really needed to do something different. And we know, and Adrienne talked about this, access to mental health treatment is not good. Access to substance use treatment for pregnant women was even worse. It's improved in Montana through a lot of effort across a lot of partners across the state. We knew coming into this that mental illness and substance use were prevalent. And when we started down the road, in this project, screening, as Adrienne talked about, for prevalent mental illnesses were not routine, and certainly screening for substance use was not routine. What often happened in terms of substance use screening was if you looked like you were using drugs, then you got tested, urine tested. Otherwise, screening was not prevalent. And so what's happened, we can go over the next to the next slide. What happened was the Meadowlark Initiative was established in 2017 by the Healthcare Foundation because of all the reasons I just said. And then we were fortunate enough to get one of those grants that Adrienne's organization advocated for, which allowed several things. One was it allowed for this already existing partnership between the foundation and the Department of Public Health and Human Services to get even stronger. And it also allowed the Department of Public Health and Human Services to start what we call the PRISM for Moms line, which is the psychiatric consultation line. There also is a strong partnership in Montana, and this has been really key to the success between Child and Family Services and the Meadowlark Initiative. And that is at the state level. We have regular meetings, we coordinate with each other, and then at the level of every practice. And that's just been really key to shifting some of the culture that has surrounded maternal care. And then we also have a wonderful organization, Healthy Mothers, Healthy Babies, which is a statewide advocacy organization. And we also have a fabulous research and evaluation partner to support not only the data collection that's required from HRSA, but helping practices to develop processes that allow them to become data informed and to know on the ground whether what they're doing is making a difference. Can we go to the next slide? So the idea here is that women and pregnant people have babies in the context of families, and they have babies in the context of communities. And so the emphasis really is to try to get the right care at the right time in an easy way. The slide doesn't say that, but that's part of the integration part of this, to really work at improving these health outcomes and keeping families together. That was really the vision. And this has been, you know, we're past our 5-year mark. I think we're at our 6-year mark. So let's go to the next slide. You know, this is really what the model of care looks like. And, you know, it's what's been really striking to me as I've worked with this. If we start up at the top, we've developed an integrated care model in the OB or the family med OB practice. So the prenatal care providers, the care coordinator, and hopefully a behavioral health provider. Now, I'd be the first to tell you that in the face of, you know, workforce shortages, behavioral health providers are not always available to be located in the practice, but the care coordinators in communities where that's not been possible have done a really great job of finding providers in the community who were able to provide care to this population, who have the training and expertise, and then the care coordinator becomes the conduit for information. But I also want to just say one other thing before we leave the practice team and talk about the community team, which is that, you know, we often think about the prenatal care providers, but I will say that the success of this initiative has really been dependent on that whole team. I always talk to grantees about this is a front door to back door initiative. If your front desk staff isn't on board, if the folks in billing and claims aren't on board and families interact with them, it can really send things not in a good direction. So that's that kind of whole practice approach. And then all of these really important community partners. So as I mentioned, Child and Family Services, we've got some beautiful work being done with one of our grantees with peer recovery coaches who are being trained as doulas now and are supporting people, particularly who've had a history of substance use, through the labor and delivery process. You know, we work a lot with home visiting programs and with obviously other community-based agencies for that provide all help around those social determinants of health, which are so important. Next slide. So one of the things, and again, going right in line with what Adrienne talked about, one of the first things we work with grantees around is to develop a process for routine screening for mental illness and substance use disorders. And we really have worked with them to say, everybody needs to be screened, because you can't tell when someone walks in the door what their story really is until you ask the questions. And then the trick for us, the trick to getting buy-in from providers has been having help available in their practice. Even if they don't have a behavioral health provider, knowing they've got that care coordinator who's going to help them. And as you can see, we've made a huge impact on those screening rates. And this initiative has not spread to every delivering hospital in the state yet. Next slide. So again, because this is a HRSA and grant funded initiative, we've gotten more specific than some places might be around screening tools, because we want to be able to compare apples to apples. And so we're screening for depression and anxiety. And you can see we're up to 70% of people get screened. We are using the audit C+2 to screen for substance use. And there's a lot of reasons why, which I won't go into, why we chose that particular tool. One is it's quick and easy. The other is it asks not only about alcohol, but other substances, including marijuana, which honestly is the biggest thing that flags. And I'm sure all of you on the call know the challenges with that. But that it's taken a lot of time. It's taken a lot of support, but we really have seen a huge uptick in site screening. And we've also implemented screening for social determinants. But screening is only the beginning, because if women are screened, pregnant people are screened, and there's no follow-up, then it can just feel like another example of someone not hearing my story, not paying attention to my pain. Let's go to the next slide. And so we've really developed pathways, and I've pulled out some quotes from an evaluation approach, an evaluation report that the foundation published in the spring. And I loved this quote. This one that says, because we ask more questions. I've heard stories over and over and over again, very similar to the story Adrienne told us at the beginning about her own life. I would say a very similar story with my first pregnancy and delivery, of women who say, nobody ever asked me these questions before. And yes, I was very depressed after my first baby or my second baby. Thank you for asking me. We see a lot of pregnancy and birth loss. And so again, knowing that coming into providing care is really important, because again, I'm preaching to the choir, but those of you who work in this field know that a pregnancy following a loss is a pregnancy that, is inherently challenging. So because there's all that fear and all those experiences. Next slide. So just some really quick outcomes I want to share with you. So the first one is this issue, and again, Adrienne talked about this so beautifully, this issue of adequate prenatal care. This is a tricky issue in a rural and frontier state. There are places in Montana that are 2 hours away from prenatal care. We have maternity deserts. And there are also places where perhaps the local, and this would be true in a lot of places, perhaps the closest provider may not feel safe for a variety of reasons. So when we came into this, Montana was very low on the national average in terms of adequate prenatal care. And what you see here in this graph that I wish was different colored, but is an uptick. Those solid gray lines are the increase in adequate prenatal care across the time period that the grant has been, that these projects have been going on. I will tell you that if I think about what has been the secret to success with adequate prenatal care, it is the care coordinator. And you see that in this quote. That's the person who calls and says, hey, I missed you today. You didn't come in. What's going on? I know something's going on. You know, these care coordinators meet women on the first visit and develop a relationship in addition to the provider relationship. So really paying attention to that, because we know what happens if people drop out of care. Next slide. And this one is thinking about, as I mentioned, this high rate of foster care placement. And as you can see here on this graph, all the lines are going in the right direction. What we look at here in this particular outcome is removal from the hospital. Okay, so we're not looking at removals, you know, once people get home. We're looking at removals from the hospital, which again is a really important piece of changing this story. And again, as you can see, these are going in the right direction. I will be the first to tell you it isn't only because of the work of Meadowlark. There's a lot of other work going on in Montana around strengthening families. Having said that, you know, the fact that you've got a care coordinator who can say to someone who's struggling with a mental illness or who's struggling with substance use, hey, let's get a plan in place. Let's keep track of what you do right. Let's do an informational call to Child and Family Services. Let's get a partnership going. We've had situations where a woman has shown up to deliver and a traveling nurse noticed, you know, in the results that there were substances, that the baby was substance involved, and was ready to call Child and Family Services. And the OB stepped in and said, stop. We've got a plan in place. This is a family that's been served by Meadowlark. So we're seeing this kind of change that, you know, as I always say to the teams, is changing history, changing the future one baby at a time. So it's headed in the right direction. Next slide. So just a couple other things, you know, I think this first one really speaks to the power of supporting people with social determinants. And again, if we don't ask the questions, we don't know the answers. You know, this care coordinator asks a few questions and finds out actually these people are homeless. And then I think this last one is just, again, for me, this is like when these things happen, and it happened again this week. There was an article in the Billings paper this week about a woman who had lost 2 other children. One she gave up for adoption and one to foster care, and was able to take this 3rd baby home because she got the help she needed in the beginning. She got the help she needed during pregnancy. So that's the stuff that just, you know, makes me think, and I want to go with what Adrienne said there at the end. We can do this. We can make these changes. You know, this obviously there's a foundation involved. There's been a federal grant involved, but a lot of this stuff is very doable. Next slide. Just a few more kind of comments. You know, warm handoffs have been really helpful when they're possible. And I think, you know, and I've talked to a lot of OB providers, midwives, family med OBs, and they just love having this support because their job is really hard. And we ask them to do more all the time with less. And so providing this kind of wraparound has really been a significant impact. And then, as Adrienne said, they've also got the backup of that psychiatric consultation line, and they've got a place to call that they can get help. And in a state like Montana, that's really important because there are not a lot of psychiatrists, particularly ones with experience in this prenatal postpartum period, floating around. Next slide. Before we do this, I want to say one other thing, just to thank Adrienne, because Montana is also one of those states that just expanded Medicaid through the first year following birth. And that is just, you know, again, those of you who may not work at the policy level, you know, or who may only see women for 6 weeks postpartum, having that ability to access care through that first year of life, when we know that the risk for suicide and overdose is not in those first 6 weeks. It's out into that first year. So again, just want to thank the Maternal Mental Health Alliance for all the work they do. Now you can go to the slide, to the poll, the evaluation.
Well, thank you, Joan, for your kind comments. And it's really been great to see how we can take sort of this policy, and then you've really said how it, policy meets programs on the ground. Really exciting to see all of that.
And without the policy, it's really hard to do the work on the ground. So
Yeah.
it's always it's that dance, right?
Yeah.
Down and up and up and down.
Yep. Yep.
So everyone, I just want to thank Adrienne and Joan. Adrienne, it was just particularly meaningful for me to hear your experience and kind of have you set the tone for the importance of the work that you're doing and the work that we're all striving to do. And Joan, thank you for sharing your story as well, which I was not aware of, but thank you for sharing that and also providing examples of the solutions that you have experience with, and also kind of leaning into that data. So before we jump into the open office half hour, I just want to ask that you all answer the poll question that is on your screen. And then we will jump into that. And I really just want to say that it's a rare opportunity to be in a room or a space with two people like Joan and Adrienne. They're both very passionate about the work that they're doing, the work that they've done, changing lives, really making an impact. Because it's such a small group, we really have a great forum today to discuss and to really take advantage of the time that you have with these two women. So I really encourage you to do that. I know not a lot of questions came in through the chat, but I just really want to encourage you to kind of think through if there's anything like what brought you here today. What would you like to discuss? Pick their brains. I've done it. I have enjoyed it immensely and want to make sure that I'm making space for all of you that showed up today to really be able to have that conversation with Adrienne and Joan, just because the work that they're doing is so remarkable and impactful. So just giving you an opportunity to do that, and we can move to the next slide. Okay. So again, if there are any questions, if there are no questions, I have a few. And Maisha actually dropped our evaluation survey in the chat. So if you have to leave early, you're not able to stay for our conversation, please make sure that you complete that so that we can get some good insight into the work that we're doing and as we develop future content for our webinars. So just kind of want to open the space, not seeing anything come in. Okay, I see one question from Sonia.
Okay, so yep, I can tell you about this state. So in this last go around, more than 12 applied, but 12 received the funding. And I have them on a little slip here. This is like my little, right on my computer. I have my 12 states because these are like my babies. So it was California, and California actually received funding specifically for Los Angeles County because California is home to like at least like 1/9 of the babies born in the entire country, and Los Angeles County itself is like the size of a small country. So anyway, California by LA County, Colorado, Kansas, Kentucky, Louisiana, Missouri, Mississippi, Montana, North Carolina, Tennessee, Texas, and West Virginia. Yeah, lucky 12 states. And we're hoping we go back to Congress every year and ask for more funding. So we're hoping to expand those programs to even more states. Yeah. It was really great to hear, Joan, about like how each state is able to implement these programs to fit their target population, the unique needs of the citizens of their state. And we're actually writing a newsletter about the original 7 states and what makes each one unique. And so I'll go back and make sure that I note that in Montana, it was really this focus on substance use, which is really because of that was the unique needs of your population.
Yeah, and the other thing I was going to say, Adrienne, that I forgot to say, just in term while we're talking about that grant, I mean, I think one of the other things that grant really supported was having a psychiatrist who had particular skill and expertise in this area, not only available for individual consultations, but for training for particular teams. I mean, in Montana, a lot of OB providers, primary care providers, have to do a lot with psych meds because they don't have a psychiatrist down the hall who can come in for a consult. And her work in terms of, you know, an echo series she did, but also really being able to meet with a whole team to say, you know, let's talk about your prescribing practices. Let's talk about what's safe during pregnancy, what's challenging, what medications people need to come off shift, et cetera, and helping to work around diagnostic profiles. A lot of the calls to the consultation line turned out to be for people who had undiagnosed bipolar disorder.
Yep.
You know,
Yep.
and again, and that's a very scary disorder for, you know,
For anybody, but
for
particularly, right, a woman who is pregnant, right?
Yes.
And, you know, so I will say this, I'm not a psychiatrist, but I have spent a lot of time talking to psychiatrists in this field. And bipolar illness in particular is the one illness where they want to ensure that the woman stays on her medication during pregnancy. If she goes off her medication, there is like a virtual guaranteed relapse. And then she needs higher care. She needs more medication. Often she needs to be hospitalized. And so, you know, the bottom line or the rule of thumb that I've heard from these reproductive psychiatrists is primarily if a woman is on any kind of psychopharmacologic medicine, anything that's treating her mental health, if she becomes pregnant, she should stay on that medication, particularly for, again, women who are bipolar, have bipolar illness. But also do not immediately go off your medication without consulting with your doctor, right? Because your baby has already been exposed to the medication. It needs to be a thoughtful decision about how to handle these medications during pregnancy and while breastfeeding. Yeah.
And that's where that psychiatric consultation can just be so helpful.
So helpful. Exactly.
Yeah.
Exactly. So we see
Right.
a couple of questions coming
Yeah.
in.
Hold on just a second.
Sure.
Adrienne, we have someone with a raised hand. We have 2 questions that came in the Q&A and then 2 that are in the chat. So I
Okay.
want to make sure that we are addressing them in the order in which they came in. Maisha, I believe you gave the person with the raised hand an opportunity to come off mute and ask their question. So I just want to make space for that and then can go through the Q&A. Okay, it looks like it's Marlissa. Marlissa, do you want to come off mute and ask your question? Okay, so we will, okay, it looks like her hand is down now, so maybe that maybe that was an accident.
Sometimes you hit that hand and you didn't mean to.
Yes, no problem. Okay, so the first question that came into the Q&A was related to addressing stigma and kind of the challenges with addressing stigma by providers and staff, you know, thinking about perinatal care providers, but not limiting it to those particular providers. So like, what are your thoughts on addressing the stigma that may be present in these situations?
Yeah. In my mind, you know, stigma, it's so pervasive around mental health. Right, but particularly around maternal mental health, because this is, as I showed my early pictures, this is supposed to be such a happy time. And for many years, people thought that pregnancy was actually protective against mental health conditions. That, you know, for whatever reason, if you're pregnant, you're happy. Well, not always, right? And so I think a lot of this, to me, the conversation about mental health needs to start with the provider, whether it's the primary care provider, the obstetric provider, a nurse, whoever. It is so hard as a mom to acknowledge that you're struggling in this period of life when everybody thinks it's supposed to be so joyous. So to have that conversation start with the provider to say, hey, you know, anxiety and depression are so common during pregnancy. In fact, it's the most common complication. We're going to check in with you every time how you're doing. I'm going to ask, and, you know, I want you to be honest with me. This can be a very challenging time in life, and we'll get you connected with resources if you need them to help dispel that stigma, like take the air out of this huge problem by normalizing it, by being the first one to talk about it. So that's what I often feel is the first step to address stigma. What are you thinking, Joan?
Well, it's interesting because, you know, because I've been the technical assistance provider on the ground, and this isn't just in this Meadowlark approach, this is across the board in the integrated care work I do. I'm pretty convinced that as soon as you're asked to implement universal screening, part of it is a logistical, one more thing for me to do. But part of it is we have to confront our own internalized bias.
Mm.
And all of us have internalized bias. And Adrienne, I agree with you in terms of, you know, it really comes right to the fore when we're talking about people who are pregnant, because you're not supposed to be depressed, right? And if you're using substances, then you're automatically a bad person. None of which, and the history around this is not good, right? We've got lots of examples across the country where, and unfortunately it still happens sometimes, if you're pregnant and you're using substances, a judge may sentence you to jail to keep you from using substances. Well, what does that do except reinforce that stigma? So I agree with you, Adrienne, 100% around, helping providers and whole teams have language in terms of how to talk about this, just like what you just did. I wish I had that on a tip sheet, right? Because that's the kind of conversation you need to have. We screen everyone because we know this happens. Like, this is a potential complication, just like, well, I was going to say hemorrhoids. Maybe I shouldn't say that, but like, things happen when you're pregnant. Like, yes. And if you're using substances, this is a great opportunity for you to get into recovery, because we know you care about your baby. We know you want to have a healthy child. So we can help you with that. That's how I think we get to this issue of stigma.
Yeah.
But it's rampant. It's rampant.
And stigma is huge. I talked to an organization yesterday who have launched a 20-year project, a grand challenge to eliminate stigma around mental health. So 20 years. So, I mean, this is huge. This is huge. Stigma is huge. And just the more we talk about it, the more we acknowledge that it's real, that it's common, that lots of people experience this, and we can help.
And
right?
we can help. Yeah.
Thank you.
Yeah. And I think, this is a little bit different than the stigma around mental health and substance use. But I think, when you look at the data around Black women, when you look at the data around Native women, we also have to really look at how do we develop systems of care that are culturally responsive.
Absolutely. Yep.
And work with, again, all of us around our own internalized bias regarding race, economics, class, because all of those things can be barriers to people getting the care they need when they're pregnant.
Yep.
And that only increases the chances of complication. We've done a ton of work. We've got one of the grantees in Montana who has just really worked to change their culture throughout their organization, throughout the hospital, the NICU, their outpatient OB practices, to be ones that are more responsive to the women in their community. Were you going to say something, Adrienne? I saw you popping with an idea.
Oh, just so many ideas. I'm reading one of the comments in the chat that I want to respond to, but I'll let Shannon moderate all of those. But
a lot of great stuff coming through. It's like I said, whenever, I enjoyed my time having conversation with you and asking all of the questions and all the things. So I'm really glad that people are popping into the Q&A and also into the chat. The next Q&A question that I have for you is, how do you advocate for balance, or what is right, or what is the right balance between promoting breastfeeding for babies' health and bonding, but also the line, particularly when struggling with breastfeeding, when this may be negatively impacting maternal mental health and impacting the baby's health by association?
Oh, I have got to take this, because this is one of the things that is nearest and dearest to my heart, is this link between mental health and breastfeeding challenges. And I see it over and over again. So I used to run support groups for new moms who had postpartum depression or anxiety, whatever, perinatal mental health issues. And we probably spent as much time talking about breastfeeding or infant feeding as we did about their mental health. And every single mom in our support groups had some issue or concern about infant feeding, whether they wanted to breastfeed, but they couldn't, or they didn't want to, but they felt like they should. And this tension between these two things. So here's my bottom line. I say breast is best, except when it's not. And for each mother-baby dyad, it's a different story. And so each woman, each parent needs to figure it out for themselves. And, you know, there's so much pressure. Breast is best is breast, exclusive breastfeeding for 6 months, continue breastfeeding till the baby is 2. For some people, that's wonderful. For other people, they want to poke a needle in their eye every time their baby is brought to their breast, right? And so it is this delicate dance between the two. So I will just tell you what I did, because I can only speak to my experience. So part of what I believe was contributing to my emotional health when my son was born is that he would not take a bottle, and he was up every 2 or 3 hours. And so therefore I was, and this went on for months. And I am a very sleep sensitive person, and I was literally going insane from the lack of sleep. So what we did when we had a third baby, we said right away, that baby's getting at least 1 bottle a day, because I needed to get 4 or 5 hours of sleep, right? That is like the minimum amount of sleep that anybody can survive on. And so, like, I had a 4-year-old, a 2-year-old, and a newborn. So the 4-year-old and 2-year-old would go to bed. I would go to bed in the basement with earplugs in, sound machine, whatever, you know, mask over my eyes. And my husband would stay up with the baby and give her a bottle of breast milk or formula or a bottle of beer. I don't know. I don't care. I'm sorry. I shouldn't joke about substances, but I was like, I needed my sleep because I had 3 little people that I needed to care for all day long. Right. So I'm being a little flippant, and perhaps I shouldn't be, but you know, this was how we dealt with it. Right. And then so I would sleep from like 8 p.m. to like midnight, and I would wake up because I was primarily breastfeeding. And then I would take the baby and my husband would sleep. Not romantic, but this is about survival, short term, you know, a few weeks, a few months to get through the worst part of it. And so, I mean, I have done research about the impact of breastfeeding on women's mental health and vice versa. And so there is no easy answer. So I just come back to, I say, you know, breast is best except when it's not. And every mother and baby makes that decision. And by the way, just because the mother wants to breastfeed doesn't necessarily mean the baby wants to breastfeed. I mean, there's 2 people in this relationship. Some people it's super simple. Some people it's painful. And again, it can be varied on each baby. I mean, I had 3 children. I breastfed all 3 of them. Each one was a very different experience. If I had the 3rd experience first, I probably wouldn't have breastfed the other 2 because it was so hard and painful. So anyway, I could go on and on about this topic. But I think it really comes down to we have to do what's best for the mother and the baby.
Yeah, Adrienne, I just want to second that. Oh, you and I could tell each other stories.
I know.
I can tell. I'm just like, I'm trying to decide what should I say, what should I not say. The only thing I would say is I think one of the things that's, you know, you referenced that I just cannot say how much I think, how important I think this is about breastfeeding and all other aspects of that early going is support. You know, those I had one of my youngest daughter had the good fortune to go through centering pregnancy when she was pregnant. And then the follow-up group, you know, she's still friends, you know, 9 years later with some of the couples they met in that group. And for her, you know, as a new mom with her mom living 5 hours away, her mother-in-law was 3 hours away. That group was really what, you know, that wrapped around her and supported her. And, you know, I see it over and over and over again with, you know, new moms in my community at church, you know, having that non-judgmental support group. I'll just say that, you know, I can't say enough about it. And I think particularly around these questions of breastfeeding, that support is just, you know, when I had my first daughter, my husband was in seminary, and I thank God every day that across the hall was a woman who had had a baby 1.5 years before, who was there for me every day, because my husband was working in home repairs during the summer. He was gone at 7 o'clock in the morning. He didn't get home till 6 o'clock at night. And like you, I wasn't sleeping. And she was just great. And she, you know, I would never have successfully breastfed without her, but that doesn't mean that everybody's got that support.
Exactly.
So I'm totally there with you.
Yeah. And one thing, Joan, that you said, I often talk about this. You know, my mother said when she had us, and this was, you know, many years ago, 1960s, you know, her mother lived down the street, her sister lived around the corner. All the young moms stayed at home on her cul-de-sac. So they were all there supporting each other. And we didn't have that.
Yeah.
In many situations today in our country. A lot of people don't live near their family of origin. They're even if they do, perhaps the grandmothers are still working, right? Because if people are working longer, they can't be there to help blend that day in, day out support. And so, each of us, again, we have to do what's right for our family, for our mental health, our physical and mental health, and no judgment. Whatever you need to do to survive is what you need to do.
100%. I have our next question. And it is, does this program, and I'm making the assumption that they're referring to Meadowlark. If the person that asked this means something different, just let us know. Does this program address parental resources that look at preventative care for both the mother and the child? So for an example, postpartum depression or a physical health disorder.
Yeah, I would say, one of the things, yes, I would say, the physical health disorder, I actually think the teams I work with they're really good at picking up on that stuff. I mean, these are experienced. I don't know how many of you are from rural and frontier states, but I'll tell you, I live outside of Philadelphia, so I'm used to I need a specialist. I go to the University of Pennsylvania, for somebody who treats hangnails on your finger, and it's there, right? I'm exaggerating, but I have been so impressed with the medical care in some of these small communities in Montana. These are people who've had to learn, and so they treat all of the above. I also think, this preventative care, we're really working with our teams. This has kind of been an emphasis over the last year and going forward, to think about what kind of education are we giving families during the pregnancy, including around perinatal mood disorders. And so our teams are, educating not only the pregnant mom or person, but also who are the natural supports, and saying to the natural supports, if she's in trouble, you may see it before she does. And giving them some concrete, these are the things you need to watch for. Again, this happens. It's not because anybody did anything wrong. This is just potentially part of the experience. And so I think in that way, looking at those preventative care, and I think the other piece of preventative care really is, I mentioned this quickly, but getting people connected to home visiting programs. I remember, again, Adrienne, back in the olden days, when I was in my undergraduate nursing training, I did home visits on, a woman had a baby, she went home, and a nurse showed up the next day or 2 days later. Like, okay, now what did I know at 20 about a baby? But, I was learning, and at least I had book knowledge. And I think, seeing some of that start to come back, I think that's a hugely preventative, Adrienne, when you talked about $14 billion, I thought what we could do with that $14 billion, having everybody get a home visit. One of my daughters had a doula for every one of her deliveries. And, her doula came after the baby was born to say, are you doing okay? What else do you need? How can I help?
Yep.
I think all of that falls in the prevention area.
Yeah. In the UK, in England, every mother gets home visiting nursing for like 6 weeks. Every mother. Yeah. Yeah. And it used to be, again, you think a generation or two ago, doctors like delivered the baby at home, right? And then they came back and visited the mom. And we just, our medical system has changed so much that we really do need more of this home visiting, more of this personal care, this follow care. How's it going? How are you doing? This can be really tough. What can I do to help?
Yeah. And a lot of our care coordinators have developed a system where, if they don't get to see mom when the baby's delivered, even if they do, but they're calling regular intervals at a week.
That's great. Yeah.
At 2 weeks, they catch them on that 2-week postpartum visit.
Yeah.
When they bring baby in, really kind of staying in touch.
Yep.
And we've really shifted our emphasis in this new grant cycle to looking at that first year of life for all the reasons you said, because when baby transitions, when mom transitions out of that OB care and baby is just going to the pediatrician, that's another potential danger moment.
Yeah. Yep. That's why it's so important that pediatricians are also checking in on the parents. Yeah. I worked with one pediatrician. I love this gentleman. He said he makes both parents come in for the 4-month well baby visit. So he can check in on each of them and also talk to each one separately. How's the other person doing? Right. So that was
that's
his,
great.
yeah, that was his requirement of his practice. Yeah.
Love that. And that 4 months is a really important time to do that.
Yeah.
Okay. Thank you, ladies. I have an additional question for you. We are going to keep them coming. So are you aware of any successful models that bridge the gap between the ambulatory and inpatient settings? So when the mom is a patient in labor and delivery or during a NICU stay?
And not sure I understand the question. Are you aware of?
Adrienne, let me jump in first.
Okay.
I think I sort of know Vicky. So I know Vicky.
Okay.
Oh, okay.
So Vicky was at one of our Meadowlark sites before she left for greener pastures. I still miss her every day. But I think so, Vicky, I think, you know, at the time when you left, one of the things we're really working on now in terms of developing out this Meadowlark approach is exactly that. So that, you know, I'll give you one example. One of our grantees has what they call a green sheet, which is, and it's literally a green piece of paper that they fill out in prenatal care for moms who they're concerned about, that they think, you know, there may be an issue, and they talk to the mom knows this, they're engaged in this process. The green sheet goes with that pre-delivery paperwork at about the 28 or 30 week mark up to the maternal baby floor, so that the staff on that unit know if they see a green sheet, then when that delivery happens, they need to call the care coordinator and let the care coordinator know. And then either the care coordinator and or the behavioral health provider come up to the unit. They're doing some of that same follow through with families in the NICU, because again, that's a really, it's just, that's such a tough experience. I wouldn't say that we've got it nailed, but it's definitely beginning to take off. A lot of the outpatient teams are rounding now on the mother baby unit and just popping in and checking in on the people that they've been working with.
Yeah. And then more specifically, I went back and I was reading the question again. So there are mental health programs that focus on pregnant and postpartum women, intensive outpatient programs and partial hospitalization programs. So these are specific mental health models. So intensive outpatient programs are usually like 3 days a week, 2 to 3 hours a day, mom and baby, typically baby, coming and getting, you know, mental health care, maybe some group therapy, maybe some medication management. And then the next step up would be partial hospitalization programs, which are even longer. They're typically 5 days a week, between 5 and 8 hours. And again, mom comes most often with baby, right? And they do dyadic care. There's a nursery for the babies. The moms are getting treatment. They're learning how to interact with their babies, all of those things, increasing that great attachment that needs to happen during that time frame. So these are specific programs, and there's not many of them across the country, but very targeted programs to help women who are experiencing, you know, moderate to severe mental health conditions. And so there are a few of those. One program that I always dreamed about, I call it the living room. I thought, wouldn't it be great if I just had a place that moms could come to and hang out? It could just be the living room. They could come with their baby. There'd be other moms hanging out. You know, if you're home alone, maybe you're home on maternity leave, or, you know, you don't know anybody, you could come to the living room and you could meet other moms. You could have, you know, there'd be snacks and stuff, but it would be like, I just remember how lonely and isolated I was at home with my first child. I had been working up till the day she was born, and now suddenly I'm home. It's the middle of the winter. I don't know anybody. I'm depressed, right? Just have somewhere to go to hang out. So I've always dreamt about that. Maybe that's what I'll do next. I'll start the living room.
We will be on the lookout for that for sure.
Yeah.
Can I just jump in and say one more thing? Adrienne, are you familiar with Hushabye Nursery?
I am not. What's that?
Okay, so this is one of my other favorite examples. So Hushabye Nursery is in Arizona, and it was started by a NICU nurse, Tara Sundin, who saw these babies who were born with opiates on board and were automatically put in the NICU and all the sequelae there, and realized as they're in the NICU, parents aren't learning how to care for that baby, and that baby's going to have some symptoms for a period of time. And so she started this program called Hushabye Nursery, where it's a little more than your living room, Adrienne, but it's kind of in the same family. It's a place that's like a home where parents can come, their baby can be there instead of in the NICU, assuming they're medically stable. And they're taught how to soothe, how to manage, how to support, and there's treatment for the substance use available to them. Some families get involved prenatally, some families come there after the baby's born, but I think that's another beautiful kind of approach. Adrienne, I'll connect you to, because
Oh, I'm already on their website checking it out.
All right.
Looks great. Oh my gosh, that's amazing.
Yeah. And Tara is just a fabulous, she's really thought this through, and they've got some beautiful outcome data.
Yeah, that's awesome. Oh,
Yeah.
that's so great.
Yeah, just a really, again, it's one program, but I look for all these little sources of light, and I figure if we can spread them around, then we get more and more light.
Yep. How do we franchise the Hushabye Nursery so it's everywhere? Yeah.
She would do that. Yeah, Adrienne, if you can find her funding, I can tell you she'd be on board for that.
Hushabye Nursery. Yeah.
Yeah. So speaking of funding, another question. Should the states that do not have the funding, Adrienne, that you mentioned earlier, lobby their state legislators to provide additional funding for this initiative to allow more states to participate?
Absolutely. Absolutely. And I think, as I said on that map, there's like 28 states that have some version of these programs. And so there's only 12 that are getting federal funding. The others are getting funding somehow through their states or launching them, often in collaboration. It's typically like, the public health department, so some form of government, and typically a university is involved. But there are many of these psychiatry access programs, yes, that are funded purely on state dollars, not federal. Yeah. Our goal, of course, is to get all 50 states funded with federal dollars. Like, why should we have to compete? Why should states have to compete for this, for funding for these services? It just doesn't make sense. It should be like part of Title V funding, or block grants or something.
Okay. And then we have a question from Vicky that was, what was the name of the program again? I think this was around the time that you were speaking of. I think it's Hushabye Nursery, and I'm not 100% sure, but I think that's around the time that this
Hushabye Nursery. Yep.
Okay. I'm going through the questions one more time just to make sure I'm not missing anything. I know we're coming up almost on time.
I saw something in the chat about, having to advocate when you're already struggling, and just wanted to touch upon that. That is so hard. And so just want to send, just recognition that it is so hard to advocate for yourself when you're already down. And that's why, I keep putting this emphasis on the providers as the person to have to start that conversation. I just remember how hard it was to, number one, acknowledge that I was struggling. I'd never struggled with mental health issues before in my life. Number two, ask for help, and then have to ask for help repeatedly, right? And I just wanted somebody to, like, what I call, give me the verbal hug. Like, I am so sorry you're having a tough time. You know what? Lots of moms go through this, and I am going to help you. I swear, if somebody had just said those 3 things, I would not be doing this work, because it would all be done, right?
So it's good they didn't say those things.
Oh,
you need to be doing this work, but I'm sorry.
Yeah. So Ebony, I think that is who put that in the chat. I'm sorry that you're struggling. There's lots of people on this call who can help, and just, hang in there and reach out. We can follow up or something, but I just want to acknowledge how hard it is to ask for help when you already need it.
Yeah, I agree, Adrienne. And I just want to underscore what you said, because I think sometimes at the policy level, at the, kind of workflow, all that is some complicated work. But at the end of the day, some of this is really simple. It's really about, my heart sees your heart. And I know this is hard, but I'm here. And let me connect you with some resources. It's so for any of you who are kind of thinking, that, oh, well, we don't have all those resources, we can't do this. I always say, look for what you can do. And man, I loved what you said. I mean, it's spot on.
And so I'll hold up again, Postpartum Support International as
Yes.
an incredible resource. So their website is postpartum.net. They have all kinds of online support groups, opportunities to connect with local volunteers in your state who know all the local resources and can get you connected with help. They have just all kinds of great programs. That's why I always point new moms. Yeah.
I agree.
Thank you. And thank you, Ebony, for sharing that with us. I have an additional question. Is there a way to leverage the maternal mortality review committees that exist around the country? I imagine they are having some similar findings.
Yeah, to leverage the maternal mortality review committees that exist. I imagine they're having, yes. So all the data that I talk about comes from the maternal mortality review committees. And so just a quick word on the MMRCs and the PQCs, just in case people aren't familiar with them. So maternal mortality review committees are multidisciplinary committees, typically at the state level. There's some at the city level, like in New York and Philadelphia. And they look at in depth all the deaths to women during pregnancy and the first year postpartum. And they have access to more than just medical records. They can get access to police reports or social service records. They interview the families. And so they get a robust picture of the circumstances that lead to women's deaths. That's where we've gotten all of this information about these maternal suicides and overdoses. So they do all of this review. And then they pass this information, they make suggestions, and they pass this to the perinatal quality collaboratives, the PQCs, which then try to do something to address these issues. And so the PQCs also are federally funded. Some of them are federally funded. And they basically focus at the hospital level. They take the safety bundles that are put out by the Alliance for Innovation on Maternal Health, AIM, and they take these safety bundles, which are like packets of information on a particular topic, whether it's hypertension, mental health. What are some of the others, Joan? I see you nodding your head. Substance use.
Postpartum hemorrhage.
Right. And so they have very specific things. Here's what each hospital system or provider should be doing. And so it's sort of this loop. So the MMRCs do the research, they come up with the data. The PQCs then say, that, okay, here's how we're going to address these issues, and down through the AIM bundles at the hospital level. Did I get that right? Did I miss anything?
No, that's perfect.
Yeah. And so if you want, these are great opportunities to get involved on your state MMRC or your PQC, because you can really, impact change at the state and local level.
And I think that data can be part of what increases the sense of urgency.
Mm-hmm. Mm-hmm. Yes.
So as we're getting ready to wrap up, and we're approaching 2:30, there is one question that came in the Q&A, Adrienne. I just want to give you an opportunity to speak to. The question was related to discussing military moms and how that would be great. I know that you all have a webinar coming up very soon, so I just wanted to give you an opportunity to kind of shout that out, since it will be here in a week or so.
Oh my gosh, thank you so much. Yes, we're super excited. I'm finishing up a fact sheet about military and veteran women and maternal mental health. As you probably doesn't come as much of a surprise, but military women face maternal mental health challenges at significantly higher rates than the general population, in part just because of the military system and the military culture. And things like, if you're a dual military married couple, you may not be stationed together. You may be worried about your spouse who's deployed overseas or in harm's way. And so we do have a webinar coming up. In fact, if it's okay with you, I'm going to find the link and drop it on in the chat, if that's okay. So our webinar is going to be the Wednesday after Thanksgiving. So that is coming up. Okay, let me find this.
Yeah, you can drop that in the chat. And then Kimmy, if you want to advance to the next slide. And I just wanted to share some upcoming events that are National Council for Mental Wellbeing events or webinars. Like I said earlier, you all will get access to this slide deck that will include these registration links. We will make sure that we also pass along the link that Adrienne shares for her upcoming webinar related to veterans that are experiencing maternal mental health and kind of what that looks like for them. So just making sure that you know that you will have access to this information and still have time to register for these events. Next slide, please. Thanks, Adrienne. And for those of you who are interested, Adrienne dropped the registration link for the military families and maternal mental health webinar in the chat. These are a few resources for you all just to check out. And then also, if you go to the next slide, there are some additional resources that Adrienne shared. She mentioned some of those. So just honestly being sure that you're making sure that you're utilizing the information that has been presented in the webinar and digging into these resources, figuring out how they can support not only you, but also your patients, and kind of coming full circle with your whole organization as far as increasing buy-in and with the work that you're doing. And I don't see any additional questions in the Q&A or the chat. So we will be here for the next few minutes in case anyone wants to stay on and ask any questions. I just wanted to make sure that I let you all know about those upcoming events, and then also the resources that we have available for you that speak to maternal mental health and the content that we covered today. We also appreciate you all for taking this hour and a half out of your day, spending it with us, discussing with us. This has been such an engaging and rewarding conversation. So thank you all so much. And we will be here for the next couple of minutes. So
awesome. Thank you, everyone. Thank you, Shannon, for moderating so nicely, and to your team for all the support that goes into pulling off these webinars. I know how much time and effort it takes. So I just want to acknowledge the crowd behind the Zoom room, making it all happen.
Yeah, thank you so much.
Thank you.
And heading into the Thanksgiving holiday. I hope everybody travels safely and enjoys their turkey, and
yes, all the food, all the things.
Yep. And all the stress that also comes with it.
Yeah.
Yeah.
All of that too. So we're just getting a bunch of people dropping in the chat, thanking you all for your time and the content that you covered today.